So this became adjuvant chemotherapy of breast cancer instead of our early studies in metastatic breast cancer. At the time, Richard Cooper in Buffalo, New York, had treated breast cancer as a private practitioner and taken from the literature 5 different drugs which had activities of about 20% apiece: vincristine, prednisone, cyclophosphamide, methotrexate, and fluorouracil. And in fact, the NCI came up to look to see whether his data were falsified, which they were not. And so the Cancer Institute decided they would start a study, but in reality didn't have the resources, and so contracted with the National Cancer Institute of Italy in Milan, and a seminal paper by Gianni Bonadonna and Umberto Veronese was this, the straight green line versus the control. This was CMF versus control after operation of women, and I've plotted here those who had 4 positive axillary nodes or more. And the CALGB used Cooper's regimen, which was vincristine, prednisone, cyclophosphamide, methotrexate, and fluorouracil, and its CMF control, and it was significantly superior. And 20 years later, these curves are still divergent in an analysis done by Ray Weiss. Then Larry Norton was a member of the group, and he had, at the Cancer Institute, before he joined me at Mount Sinai, he had demonstrated that human cancers follow the Gompertzian curve, and this curve done by Laird many years before was related to tumors in different species of animals as well as to pregnancy. This is the way cells grow and populations grow in a confined space. There's a logarithmic phase and logarithmic deceleration, but down at this end it's also logarithmic, and it takes just as much treatment to eradicate that last few cells as it does to get major regression in tumors. And so these are graphs that Larry drew demonstrating why CMFVP wasn't successful as a cure for some patients, because indeed, while the population was regressing, there was another population of cells that emerged. These are the resistant cells that Lloyd Law had shown in his experiments pre-existed, not related to the treatment. And so Larry's concept was indeed you ought to have 2 intensive treatments, and this is one that we did with CMFVP, followed by vinblastine, adriamycin, thiotepa, and halotestin, a regimen we called VATH, and in fact, you could kill off the second population, and these are the data for those who had 4+ nodes, again, superior to CMFVP. In reality, the Norton-Simon hypothesis was in contrast at the time to the Goldie-Coldman hypothesis, which thought that you should rotate all the drugs, course A, course B, course A, course B, to get treatment that way. And in that context, Gianni Bonadonna did that experiment in Italy. He took the Norton-Simon hypothesis and the Goldie-Coldman hypothesis and treated AAA, BBB, or AB, 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 and indeed the Norton-Simon hypothesis won by a substantial amount. During all this time, we were really influenced greatly by Howard Skipper and Frank Schabel and the Southern Research Institute. And this is a critical experiment done by Griswold at the Southern Research Institute. Here's a plasmacytoma in hamsters, and on the left you can see the growth of the tumor beginning to follow a Gompertzian curve. And if you treated it with a single dose of cyclophosphamide at the arrow, the tumor regresses, and you can see the tumor regression and then begins to grow. But in reality, if he took biopsies of the tumor and explanted it to susceptible hosts, the true lethality is shown on the right with a huge difference, because this represents residual detritus of cells that are dead but not growing, and here is this extraordinarily rapid regrowth predicted by the Gompertzian curve, so that indeed, when this point occurs, the growth is going up as shown. We learned from this that timing of chemotherapy is crucial. We also recognized, and here's an easy way to see it, that tumors are not homogeneous. This is metastatic melanoma, and you can see white and black nodules. And if it has internal metabolism differently, certainly different tumor cells can metabolize drugs differently. And I showed you tumors I consider curable and tumors that are subcurable requiring surgery. I don't think there are incurable cancers. I think they're precurable. We're just ignorant in how to treat them yet. We want to prevent them, but we really want to treat them for cure when they occur. But as of today, our responsibilities, I think, are to be sure that the quality of life is worthwhile, which entails freedom from pain and, where possible, freedom from dysfunction and freedom from anxiety and depression. And then prolongation of life. And last, tumor regression, which at the outset of the CALGB, we were measuring tumors with calipers. Now we don't do that. I am convinced that the Cancer and Leukemia Group B, as Tom Fry pointed out, has been, and as Eric just gave in a marvelous talk, the CALGB has been the crucible in which we have generated friendships as well as meaningful data, and that the world has been a better place for our activities. I expect, under Monica's leadership, that the CALGB will continue to be a prosperous intellectual fountain, and I hope that that part of the CALGB influence will maintain that same concept and discipline in the Alliance. We haven't done so bad. When you look at what happened between 73 and 87, the cancers in blue, which I'll read if you can't see them, the top is all cancers: breast cancer, brain tumors, pancreatic cancer, laryngeal cancer, leukemia, colorectal, oral, ovary, thyroid, stomach, bladder, children under the age of 15, uterus, cervix, Hodgkin's, and testicular cancer, all showing a change in mortality. And only those 5, I guess 6 at the top are worse. And the leading one, of course, is an increase in mortality in lung cancer among women, because they were later than men in starting smoking and later in stopping. We have reason to be happy that we are demonstrating a certain level of activities. And in 1972, the American Board of Internal Medicine saw fit to make medical oncology a board specialty. And you can read the principles in the Annals of Internal Medicine, written under the chairmanship of B.J. Kennedy, who's here, the late B.J., who was a member of the CALGB, a distinguished member. B.J. is the third from the left. The man on the left is the secretary of the board, and I can't remember his name. But on the far left, next to him, is the late Paul Carbone, who chaired the Eastern Cooperative Oncology Group, then B.J. Kennedy, then Paul Calabrese, also gone, And the three remaining people who bedeviled many of you in your exams are Al Owens, Tom Fry, and myself. And I think the groups themselves have been the basis for the evolution of medical oncology, and I expect that, in fact, we will continue to see translation of basic science to the activities of individuals in groups to the benefit of patients. I thank you.